I'm Dr. Tom Roberts. I've been part of the organizing of this. Thank you all for coming. This is our final afternoon session of this year's Mansfield conference, which is the 30th anniversary of this whole thing. It's really been incredibly exciting for a policy wonk like me to get to attend all these things and hear what people from all around the country have to say. Certainly, insightful and interesting. But what I'm really interested in is, how does it translate into the groundwork? What really goes on, and what's going to happen to our state? So I'm especially proud and happy to have this discussion this afternoon, where we get to invite some very distinguished and involved people who are involved in healthcare in this state in very on-the-ground kind of ways. And so it's going to be a neat session now, and then we've got another one about the future of healthcare in America and in Montana. We're going to change it up a little bit for those of you who've been here for some of the other sessions. Instead of having one or two major speakers, we're just going to have a roundtable here. Anthony Johnstone is going to facilitate that. And I think the format will be maybe an hour or so of listening to our really smart and insightful and capable crowd here. And then we'll take some questions and answers. I think that's the plan. So maybe we can get a little discussion going about Medicaid expansion. Very, very critical issue to Montana. So thank you all for being here, and thank those of you that have been here for the whole time. Anthony?
Thanks, Tom. Is this working? Good. So I just wanted to start, the title of this afternoon's roundtable is The Future of Healthcare in Montana, Medicaid Expansion in the Big Sky State. And because it's our first of these last two closing roundtables, I wanted to, it's been great to see how many people have been coming back for more and more of this. I wanted to take this theme a little bit and the theme of individual rights and social responsibilities and suggest that you might be able to frame it in a couple of different ways for this particular issue of Medicaid expansion. In law school we call this fighting the hypothetical, but I think when we talk about individual rights and social responsibilities, people kind of think, well, okay, so Medicaid expansion is the kind of warm communitarian view of things, and the concerns about it is a strong kind of libertarian individual rights view against it. I just thought, in terms of framing this, that there might be more than one way to look at individual rights and social responsibilities in this. So I'm going to start out just making some brief remarks about that, and then we'll introduce our speakers for their opening statements before we start our discussion. There have long been two views of liberty in political philosophy and ethics. There's the negative kind, the modern kind of liberty, where it's freedom from restraint. And if you think about the Medicaid expansion, well, sure, don't take my money. I have this freedom from government taking my money and spending it on Medicaid. And this is a deep principle nationally. It's in the Montana Constitution. It's expressed in our Bill of Rights in Montana, that we have an inalienable right to seek health in all lawful ways. We don't have a right to health. There was a time when the Montana Supreme Court said that there was a right to health care for the indigent, and Montana amended the Constitution to take that out. So we have this negative liberty view, and this is something I think we've seen. Megan's talked a little bit about this as well, in terms of this negative liberty. But there's also a way to view this issue as a question of positive, or what's sometimes called ancient liberty, in terms of autonomy. And we've heard those themes too. I think Mark Hall talked about it. Jim Marone has talked about it as well. Our very first speaker, Paul Lauren, made a good case and discussed about health care as a human right. And so as an individual right, it's not clear exactly which way they cut. There are at least two ways to look at the Medicaid expansion. One of trying to limit the government's interference in terms of taking your tax money and spending it someplace else, but also perhaps government offering some positive form of liberty, a more ancient form of liberty to enable all Americans perhaps to reach their full potential. The same thing is true of the social responsibility. I don't think there's just one way of looking at that. Social responsibility, sure, it could mean this kind of social responsibility where we're all taking care of each other by paying our taxes and pooling them and asking our elected representatives to send them to public spending programs like Medicaid. And that's one form of social responsibility and community interdependence. But I think in the discussion over the Medicaid expansion, we're hearing at least one other kind, a different kind of social responsibility, and that's the concern over spending, the concern over intergenerational community interdependence, and our federal fiscal situation, and the concerns about debts. That's a kind of social responsibility, too, that we're hearing in these debates. I think the arguments, just as the arguments for Medicaid expansion can sound in rights as well as responsibilities, I think the arguments against Medicaid expansion can sound in responsibilities as well as rights. We hear it a lot in the legislative discussion, are we being responsible stewards of our fisc? And so I wanted to mix that up. I don't think the framing is quite as clear as we think about these issues. There are rights and responsibilities on both sides. Let's turn to this particular issue of the Medicaid expansion. It's the kind of idea that only a lawyer could love, and I guess maybe that's why they've put a constitutional lawyer on this panel to moderate. This wasn't anyone's idea to create a Medicaid scheme and then offer states the opportunity, depending on what any one state wants to do, to opt in or out of it. It's so crazy that only a lawyer can think of it. In fact, only 3 lawyers thought of it. Those 3 lawyers happen to be 3 of the 9 justices on our Supreme Court. In the Affordable Care Act challenges, the health care cases, 7 members of the Supreme Court decided that it was a violation of another form of rights, states' rights, the rights reserved to states, to basically tell the states that they could either jump into expanded Medicaid or we're going to take all the Medicaid funds and go home. That the federal government couldn't do that. 7 justices agreed with that. The problem was that of those 7 justices, 4 of them wanted to strike down the entire Affordable Care Act. And 3 of them in the middle there, just 3 of 9, came up with this idea that we're going to create this option. You can opt in and out, and that is the world we're living in now, a world created by 3 of our 9 Supreme Court justices in this constitutional challenge that was brought. And just by way of introduction and just to tee up this debate, I wanted to explain why that happened. Chief Justice Roberts wrote the opinion that gave this Medicaid expansion option. And this is how he described the principles behind their move. And it's principles I think we're going to see come up in the policy debate here. The Affordable Care Act, he said, expands the scope of the Medicaid program and increases the number of individuals that states must cover. And that's the basics. But he said the financial inducement, his quotes, Congress has chosen is like a gun to the head. The threatened loss of over 10% of a state's overall budget is economic dragooning. Sometimes they say commandeering. They can't get their naval and army metaphors right. But it's economic dragooning that leaves the states with no real option but to acquiesce in the Medicaid expansion, or coercing the states. That, the court held, was unconstitutional. But these 3 then went on to say, nothing precludes Congress from offering funds to states to expand availability of health care and requiring states accepting such new funds to accept the conditions on their use. So the new funds can be conditioned, but you can't take away the old funds. That's the choice that Montana's facing. Now, the concerns about this remedy were expressed by Justice Ginsburg in dissent, and this is, again, this isn't kind of highfalutin constitutional law. It's really the kind of base policy arguments we're going to see today in terms of framing it. Justice Ginsburg said, well, Congress should be able to expand the classes of needy persons entitled to Medicaid benefits. Any other rule would scarcely serve the interests of federalism. The idea that states have this separate sphere of rights, that we in Montana have, ought to have more control over our government here than the federal government should. The alternative to conditional federal spending, it bears emphasis, she says, is not state autonomy but state marginalization. Citing Medicare as an example, Congress could have established Medicaid as an exclusively federal program. Absent from the nationalized model, of course, is the state-level policy discretion and experimentation that is better served when states maintain a meaningful role in the implementation of this federal policy. And, of course, that's right. Essentially, the court was saying that to the extent you want to universalize or create greater access to health care, the way that Congress has to do it is to do it itself, is to do a true federal takeover of health care under the health care cases, under the Supreme Court's decision. Doing it halfway through Medicaid by sharing responsibility with the states was not an option in this Medicaid expansion. So those were the two sides, and I just wanted to close with one more policy perspective before we turn to Richard to describe the situation in Montana. This last policy perspective came in one of the briefs of one of the parties to it, and this was their argument. This is what would happen if you upheld the Medicaid expansion in any part. Because the Medicaid funds used to induce the states come from their own taxpayers, right? Those Medicaid funds that we are trying to get back are taxes that we've paid to the federal government. The option of declining billions of dollars of federal funds and paying for medical care for the indigent with our own tax money after we've already sent tax money to spend elsewhere to the other 49 states, that choice is illusory. This brief argued, the choice given states is the equivalent of that offered by a pickpocket who takes a wallet and gives the owner the option of agreeing to certain conditions to get the wallet back after having given it to a stranger. That last perspective is no less than the states themselves. This was the argument they made, that if they lost, if they didn't strike down the Medicaid expansion, this is the situation the states would be finding themselves. And one of the things we'll talk about today is if the states were right. Montana didn't sign on to this brief, but the states that signed on to it, is that right? Do the states really have no choice but to enter Medicaid expansion, as these states argued in opposing it? So I'll introduce each of our panelists right before their initial presentation, and then we'll go into a conversation. The first round will have about 10 minutes, and then we'll go down to 3 to 5 minute discussion points. Starting, and I'll just introduce Richard and ask him to open up. Richard Opper was appointed by Governor Steve Bullock as director of the Montana Department of Health and Human Services, overseeing the agency's 3,000 employees. And previously, that's our biggest agency, biggest state agency by far. Previously, Richard served as the director of the Department of Environmental Quality. And I'll ask Richard to open up with an overview of Montana's choice.
Thank you. Anthony, you okay if I stand up?
Fine by me.
Thank you, Anthony. I like to stand up because I like to be able to tell who's sleeping, and the view is so much better from way up here, so thank you. No, this is great. I get to tell all of you here exactly what the state of Montana needs to do and why, and then you get to hear from Carl, who's going to tell you exactly why I'm wrong. So I'm looking forward to this. This will be a good, lively discussion. And it's great to see such a good turnout. I'm really pleased with the job the organizers did putting this together. But I'm not surprised it's a big turnout because, well, I was just telling Anthony during the lunch break, I'm still very new to my job. I've been at it about 2.5 months. I'm new to the issues. I promised myself I would not speak acronyms, right? Everybody in my agency does, and it slows my learning curve considerably. But Medicaid expansion is a BFD. And if you need a translation, please see me afterwards, okay? It is a huge deal for the state of Montana. The stakes are enormous. It's the biggest decision, the most important decision with the most impacts that the Montana legislative body is going to have to make in this session or any other session I've ever been involved with. It is huge. It's going to have lasting consequences on Montana's health, on Montana's economy, and I'm going to start off real quickly with just kind of a snapshot of the state of Montana's health. Just give you a couple of statistics. The higher the number, the worse it is for the state, okay, and these numbers I'm going to give you. We are ranked 31st in terms of smoking. We're the 41st worst state in terms of binge drinking, 45th in terms of children in poverty. We're 39th for health coverage, health insurance coverage for our population. We're 49th in terms of immunization. 46th in both cholesterol checks and dental visits. 30th worst state in terms of teen birth rates, and we're 50th in terms of suicides. So we also have about 15% of our population lives in poverty, and I believe that's 100% of the federal poverty level or below. 15%, that's fairly close to the national average, but it's 7% worse than our surrounding states. So long and short of it is, we're a relatively unhealthy, underinsured, poor state relative to others. That's just the way we are at this point right now in our history. And not surprisingly, the poorer that you are in Montana, the worse your health is going to be. There's a link between those two. That's not just true in Montana, that's true nationally, that's true in most parts of the world. And if you happen to be Native American, you are really screwed. You're going to live 20 years, 2 decades less long than the rest of us. That's how difficult it is. They have a 20-year shorter lifespan than the rest of us do. So again, I'm new to these issues, and what you do when you're new to issues is you draw analogies to things you're a little more familiar with. I used to work, as Anthony said, in the energy environmental field. So I was thinking about this recently, and here's what energy producers and distributors did in the world in which I was more familiar until recently. So what the energy folks do is they actually pay people to put in CFL light bulbs. They pay people to insulate their homes. They pay people to put in more efficient hot water heaters. And they do this for a reason. They do it because it's cheaper for them. They know this now. It's way cheaper for them to invest up front in these measures to conserve energy than it is to build a new power plant down the road to handle an increasing demand over time. Well, the analogy here is, in the health field, is our focus on prevention. So when I'm thinking about what kinds of reforms we need to do in the healthcare field, and everybody agrees we need to reform the delivery of healthcare services, first and foremost, we do need to focus on prevention, because spending that money up front, like insulating your homes, saves money in the long run, so you don't have to treat for worse problems down the road. So that's the equivalent I came up with there. Another thing energy companies are trying to do is they're trying to decouple their profits from the volume of sales of kilowatt hours of energy. And they figured that if their profit is solely tied to volume, then what's going to happen is it's going to encourage overuse. They're going to want to sell more and more electricity. That's going to increase the demand. It's going to encourage overuse. Now, the analogy there to the second component of healthcare reform, the way I see it in my very simplistic world, is that we're looking at this whole medical home model. The whole point being we are trying to decouple the profits to hospitals, to providers, to doctors from the volume of services they provide. We're trying to figure out some other way to make the medical model profitable other than ordering more MRIs, ordering more blood work, referring to more people to specialists. And this has to do in part with this whole medical home model. I'm sure we'll probably talk about that. So anyway, that's how I make sense of my little world these days. And anyway, that's simple enough, I think. Those two elements, focusing on prevention and focusing on this whole medical home model and trying to get away from volume of services. That is how I view the reform. Now, how do we get there? Well, you know, in the past, we've wanted to reform lots of things. We wanted to reform how we moved goods and services in this country 100 years or so ago when we were still young and we were expanding. So we invested in roads, we invested in bridges, we invested in our infrastructure, in our transportation system. We wanted to clean up surface water in the late 60s, early 70s, so we didn't have rivers catching on fire like the Cuyahoga River in Ohio did. Over 50 times, by the way, but most notable when a reporter from Time magazine happened to be around taking pictures. Good timing. And that started the environmental movement largely. But we wanted to change the way, we wanted to improve our water quality of our surface water, so we invested in infrastructure. So, you know, we had invested in wastewater treatment plants, so our waters would be fishable and swimmable and not flammable. That was a big goal of theirs at the time. So if you want to produce large-scale, sustainable, effective changes in how you deliver health care in this country, you have to invest more in it. You need the numbers. Well, we have an opportunity, a golden opportunity right now to do that, to invest in health care with Medicaid expansion. The way I see it, I don't think our responsibility is to decide whether to invest. It's just to make sure that when we do get this opportunity, we invest these funds as wisely as possible. We don't squander them on the same old way we do things. So why do we need Medicaid expansion, make these changes? Well, one reason is this. You know, we'll talk about this, I'm sure, later in questions and answers, but hospitals provide a lot of charity care. Mike, you can talk about that one. I'll leave that to you, but it's, you know, hundreds of millions of dollars a year in Montana alone in charity care. And that results in all this cost shifting to those of us who are lucky enough to have insurance. We have to pay for all that charity care ultimately. And, you know, really we need those numbers. Hospitals need the revenue, providers need the revenue because hospitals get reimbursed from the federal government with their disproportionate share hospital payments. We need Medicaid dollars coming into the hospitals so to cover for that decrease in funding we're going to get, among other things, from the federal government for that. In fact, the decrease in payments from the federal government to hospitals to cover their cost of charity care is partly funding Medicaid expansion, a fairly significant piece of it. Anyway, if we don't expand Medicaid, hospitals are going to have to increase their fee-for-service approach, which we're trying to get away from to make money. They're going to have to shift those costs onto those of us who have insurance. And anyway, that's the only way they can make a profit, if that's the case. And that means bye-bye reform. We're not going to see it. So anyway, real quickly, here's what Medicaid reform is going to do for the state of Montana when the legislature does pass Medicaid reform on the last day of the session. You heard it here first, by the way. We have a reporter here. Did you take that down? Okay. You heard it here first. Remember this. This is significant. Anyway, between 2014 2021, federal government is going to spend $6.5 billion with a B dollars in Montana on Medicaid expansion to cover Medicaid costs. It's too bad, the governor said this many times, it's too bad that kind of investment isn't in something like Malmstrom Air Force Base, because it's still federal dollars, but it's just not controversial. Nobody would complain about federal dollars being spent on that. They do about this, but not about something like the military. So anyway, $6.5 billion of outside money coming into Montana, and when you bring money from outside a community, even one as large as Montana, when you bring money from outside into that community, it cycles, it creates jobs, and it doesn't matter if that money is coming from the federal government or from China or from a coal company. It's still outside money coming into a community that creates jobs. The estimates, and they're solid, are between 12,000 and 13,000 jobs will be created because of this new funding. A lot of people say that figure, this is just in Montana, a lot of people say that figure is overstated. They're wrong, but they say it's overstated. The model used to predict job creation from dollars coming into a community has been around forever. It's got maybe a 5% margin of error, but let's say it's a 50% margin of error. Let's cut it in half. There's 6,000 jobs that are going to be created by this money in Montana. We've never had a jobs bill that big in Montana. And, that's 100 jobs per county that would be coming into the state because of this. So economically, it's huge for the state. Now, I just don't see how this is bad economic policy, by the way, to accept this federal funding. And, you'll hear, well, the federal government's going broke. It's already broke. I'm not going to argue that, but, saying no isn't going to fix the federal government's problems. It's only going to mean that other states are going to take advantage of this incredible opportunity, and we're not. And it will make us less competitive. We're already 7% behind the neighboring states when it comes to poverty level. We'll be less than that. We'll be worse than that. You'll also hear there's no way the feds can sustain that level of spending over time, and ultimately they're going to transfer all those costs to the states, or a big portion of them. The people who say that are right. I think we know that. Federal government's already planning to transfer a lot of those costs to the state. A lot of states have done things like put in a circuit breaker. If the federal portion of the percentage of the share that they're going to fund drops below 90 or 80%, then Medicaid expansion is over. The state stops paying for it. It means we have to drop a lot of people off Medicaid rolls. New people that we'd enrolled got the benefit of expansion for 5 years, 10 years, whatever, are no longer going to get it. But that's 5 years to 10 years of good health insurance. So anyway, you'll also hear, things, Medicaid fosters more dependence on government programs. Well, the vast majority of the people who would be added to the Medicaid rolls, not the ones who are already on it, but the ones that we would add, those are people who are working. They're working part-time. They're students who have to work part-time in restaurants. They're high school or college graduates that can only find part-time work in places or very low-paying jobs. They're farmers or ranchers who work for places that can't afford health insurance. These are our kids we're talking about who don't have wonderful jobs out of college waiting for them. So anyway, I think it's worth investing in them in health care insurance. That's my take on it. Almost done here. You'll hear Medicaid patients get lousy medical care, and that's not entirely inaccurate. People on private health insurance probably get better care in some ways, but what's worse care is having no health care coverage. Waiting till your daughter is just about dead from asthma before you take her into the emergency room and get very expensive treatment you can't pay for that only deals with the symptomatic issues. That's bad health care. Being on Medicaid is better than that, and it'll be better for our people. So let's summarize here just real quickly. Medicaid expansion is going to bring in $6.5 billion of new money to Montana. It'll create 12,000 plus new jobs. It'll allow us to develop and implement real health care reform on a scale we'll never be able to achieve if we say no to this. And it's going to offer up to 70,000 Montanans a chance to get health care coverage. Even if this is temporary and the federal dollars go away in a decade or so, for a period of time, we're going to be a wealthier, a better employed, and a far healthier state. So what's the downside here? There was an article in the paper the other day, you probably read it, it's probably been quoted here. It was a fellow from Massachusetts saying that he thought it would be insane, that's his word, insane on the part of the states to say no to Medicaid expansion. Now, I personally think he was exaggerating, but only a tiny bit. I just have to convince a few legislators still. Thank you.
Thank you, Richard. So I'll now go to Carl Grimm. Carl is the CEO of the Montana Policy Institute down in Bozeman, a graduate of Montana State University, and leads, it's okay, it's fine. I come from a long family of Bobcats. You should wear it proudly. But Carl is the CEO of Montana's only free market think tank. Carl?
feel like I'm only talking to these people over here, so I'll try to turn my head once in a while. So I'm normally in these kinds of things, I'm the grumpy old man who talks about the cost of things. Now I'm the not quite insane grumpy old man, and I'm happy with that role. I have no problem with that. Let me start by just finding common ground where I think we have it here. Too often, and one of the nice things that I've seen in this event is we've gone past the inferring of intentions. We've talked about some basic principles, the things that define us, what make us different, whether it's nature or nurture, whether we're communitarians or individualists or whatever. And we get to some of those basics, and I really appreciate that about this event. So let me start by finding some common ground here. I think all Americans and all Montanans, certainly just about all of them, believe that we should provide medical assistance to the needy. All right, the needy who are out there. We're a civil society, we're a prosperous society. We should do that. We're not going to step over bodies in the name of fiscal responsibility. That's not going to happen in our society. So what we're looking for and what we're arguing about is the best way to do that, the most effective, the most efficient, the most humane, and the fair way to do that, that's fair to everybody. That's really what this comes down to, I think, and so we're going to differ on a lot of the issues of how to do it, in some cases why to do it, but often how to do it. So I'm going to go through, I've got basically 4 points, and they somewhat address yours as well. I don't want to, this isn't a debate going back and forth, but it's going to sound kind of like one because we both have the same points. We're just on opposite sides of them in many cases. So the first one is the money. $6 billion is a lot of money, but it's not free. It's, I certainly don't think it's forever. I think that funding is uncertain at best. And I also believe it's, if you look at the history of estimates on entitlement programs like this and expansions, the estimates are always wildly low, the costs are always wildly higher, and the unintended consequences start rolling in and you end up with even more costs. And even if it is free money from the federal government, which by the way doesn't get spent by other states if we don't spend it, it's only spent, but that $6 billion is for us or nobody else. Even if you do consider it free money, it's not free money because on April 15th, you're going to fill out a tax form. 30% of that free money is borrowed from your children and your grandchildren, and the rest of it is paid for by somebody else by taking dollars out of the private economy at the expense of somebody as well. So it's not free money. I don't think it's forever. And even when you look at all the benefits, all the economic benefits, the tax revenues that come out of it, the increased jobs, the increased employment, the economic revenue, the net cost to the state is somewhere between $50 and $100 million through 2021. So that free money is costing us, after all of the benefits, that free money is costing us somewhere between $50 and $100 million. Not a huge amount of money, but what we give up for taking that money, I think it is a significant amount of money. So I think it's basically it's not free and it's not forever. And that's the other thing is I don't think we're going to roll this back. There aren't very many precedents for giving an entitlement and then saying never mind and pulling it away. Look how much we're arguing about something as simple as raising the retirement age for people under 50 or under 55 or under 50 right now for Social Security or Medicare. The hue and the cry that comes up over just some reforms that just about everybody agrees would be easy and save the system, and yet we can't do those. Imagine if we went out to 70,000 Montanans and said tomorrow morning you don't have health care insurance anymore. It's not going to happen. I don't care what circuit breakers you put in the bill. Politically, I could be wrong. I'd be happy to make a friendly cat grizzly bet on it. I'll paint my face purple or something in 2021 if that happens, but I don't think it would happen. I also think expansion is bad economic policy. It's in many cases, it's pure crony capitalism. I'm not here to bash the hospitals or the providers, but you can't swing a dead cat up in Helena right now without hitting a lobbyist from the Montana Hospital Association and some of the other providers trying to get this passed. And why is it? Because they want a chunk of that $6 billion. And that's not a bash. That happens in every industry in the country. They are reacting to the incentives that have been put in front of them, and I actually admire them for that because they have a responsibility to their boards, if they're a nonprofit, or to their stockholders or whatever. But at the same time, as the designated grumpy old man, I have to point out that that comes at somebody's expense. That comes at taxpayer expense primarily. It comes at the expense of, and I'll get into this in a moment, of what I think is going to be inferior access to care for all Montanans as a result of this. And that's not a free thing that's happening out there. And I think that we need to have a trade-off or a conversation about the trade-offs of what's fair and what isn't fair. Now, to be sure, part of that is because the Obamacare takes off DSH, the uncompensated care. That's about $11 million a year in Montana. Well, frankly, I would just as soon write the hospitals a check if we make a decision as a society that we want to reimburse the hospitals for uncompensated care for the relatively small number of people, every one of them important, every one of them their own story, but for the relatively small population that we're talking about compared to the state and the country, I would rather be transparent about it, write them a check for that uncompensated care so the taxpayers could see exactly what they're buying, rather than distort the entire health care system for the rest of the state and the rest of the country, just to deal with that one problem that we have. Let's make it fair, let's make it transparent, and again, I'm okay with just writing them a check to take care of that problem because we have decided we're going to take care of people who need to be taken care of. I think it's bad medical policy as well. Expansion recipients, Medicaid recipients encounter barriers to primary care at nearly twice the rate as those with private insurance. And so what that happens, along with a lot of sociological reasons, poverty reasons, a lot of personal reasons, they show up in emergency rooms in disproportionately high numbers and disproportionately sick and therefore expensive to treat. That needs to be reformed. We talked about the need to reform. Yes, the system needs to be reformed. So what economic sense, what medical policy sense does it make to dump another 70,000 people into a system that we all agree is in dire need of reform? Why can't we fix it? How about we work on fixing it for the people who really need it before we start putting a whole bunch more people in there who, my next argument is going to be, are on the margins of whether they need it or not. And so, again, that this would be an argument for deferral, for saying, look, we got 30 days left in the session. This is a big deal. We agree on that. This is a BFD. Thanks for almost making me spit my water out, by the way. This is a big deal. To introduce that with 30 days left in the session and expect it to get jammed through with, it's like the read the bill. Please read the bill, understand the bill. Once we accept this, it's forever, folks. There ain't taking it back. The feds are not, even if they allow us to take it back, which there's doubt in my mind whether they would once you get in, if you can get out again, I don't think politically we would get back. So there are other states, about half the states right now have said they're going to do this. Let's see how it goes. Let's see how some of those really fiscal responsibility states like Illinois and California and New Jersey, let's see how well they do with it and take the lessons from them. And then in 2015, after we've had a good chance to look at it, hey, if it's a good idea, it'll sell itself. But right now, there's nothing to sell. It's an idea with a lot of polemic on each side. And so I think I'm kind of risk averse when it comes to that, especially something that's a BFD. Finally, I think Medicaid expansion, and to me personally, this is the most important reason to defer. And I'm not saying no, I'm saying let's find out. This is the most important reason is I think it's bad welfare policy. 44%, nearly half of the newly eligible would be under 34 years of age. 75% would be childless. About a quarter would be kicked out of their private insurance, which is almost always provides better coverage and better access than Medicaid, and dumped into Medicaid, either by their employers or in case college kids, by their parents probably, or just because they're privately insured. What we're doing is we're creating a new entitlement for young, healthy, childless adults. This isn't about the disabled. They're covered well above 138%. This isn't about pregnant women. This isn't about children. This doesn't affect them except to create much more competition for the limited assets that are out there to care for them. It does that in spades. What it does is it creates a disincentive to work. What kind of welfare policy do we really want? Do we want a welfare policy that disincentivizes work that disincentivizes earned success and the dignity of making a living and taking care of yourself. It disincentivizes productivity and being a producer in society, both for the recipient by taking away the reason to do that, the need to do that, and for the provider, the person who pays the bill, by taking away the profit of doing it, of working, by taking more of their money at the margin, taking it through taxes or through competition for assets or whatever. So I think it's really bad welfare policy to basically trap another 50 to 70,000 young, able Montanans, primarily, not all of them, but primarily, into a system that they're going to have a very difficult time getting out of, that we all agree is in dire need of reform. Why not fix the system? Why not then readdress who needs to go into it and what's the most efficient way, the most effective way, and the most humane way to provide what we all agree on, which is medical care for the people who are truly in need of it.
Thank you, Carl. So now we'll turn to a couple of other perspectives. I wanted to go to Mike Foster, who is the Regional Director of Advocacy for Montana's Catholic hospitals. Are you one of those lobbyists of which Carl speaks?
Yeah, but you must swing a very big cat, because I can count about 10 of us at the most.
Well, go ahead. Let's hear your perspective, Mike.
Oh, okay. I don't know if you noticed or not, but Anthony's really smart. Thank you, and I want to thank Dr. Tom Roberts for inviting me to be here. This is really nice. This obviously is an impressive conference, and I'm glad to be part of it. And it's always a great pleasure to see my old friend and colleague, former President of the Senate, former Secretary of State, Bob Brown. And it's too bad you're not President of the Senate right now, because we're having some troubles there as far as the view of hospitals. But we'll get beyond that. The way I'd like to frame this whole issue of Medicaid expansion is that it boils down to a basic question of, are we going to figure out a way for low-income Montanans to have insurance coverage for health care? That's really what it is. And Medicaid is a tool to do that. But what we've said for many months is, well, can we be creative? Because Medicaid expansion is, of course, tied to the Affordable Care Act, which has a lot of political connotations, and we get that, we understand that. But we're trying to get to, step away from all the political stuff and say, are we going to figure out a way to find coverage for low-income Montanans? Well, we're hoping the answer is yes. And, you could ask yourself, what would $155 billion get for you? And if you boil that down to the Montana part, it's $400 million. Well, that's the amount of money that was part of a deal that the American Hospital Association agreed to with President Obama and Senator Baucus when the Affordable Care Act was being put together. And the deal was this: hospitals will voluntarily agree to a reduction in Medicare reimbursement of $155 billion over 10 years, and that's $400 million for Montana hospitals, in exchange for 97% of Americans being covered for health care. Now, the 97% went down to like 93 or 94% over time as the bill progressed, but nonetheless, that was the deal. And so I always find it interesting when people say, well, how is the federal government paying for this? This 100% of the Medicaid expansion for the first 3 years. It doesn't cost the states hardly anything, maybe some administrative costs that Director Opper could tell you about. But But how's it being paid for? Well, a good part of it is from that deal. Hospitals are paying for the coverage through reduced reimbursement for Medicare. And if you will recall, and maybe my memory is wrong too, but I think it was about 33 million Americans that they were targeting that were uninsured. And so the idea was to get them covered. Of that 33 million, nearly half were to be covered through Medicaid expansion. It was about 15 million, as I recall. Larry Putnam knows the numbers better than I do. But, you know, so that was all fine. The deal was part of the bill passes, and then as Anthony says, the Supreme Court jumps in and says, well, wait a second, on this Medicaid expansion thing, that's up to the states to decide. Okay? I'm not going to question any constitutional thought on this, but all of a sudden the hospitals that made the big deal this century are going, uh-oh, we're going to take the cuts, but half of our coverage just might have gone down the tubes. And so when I read in the paper the President of the Senate writing how awful it is that hospitals are promoting Medicaid expansion, promoting coverage of low-income Montanans, I think, well, we're paying for it. Don't you think it's logical that we might want that to happen? Plus, if any of you have any association with hospitals in Montana, and let's take St. Pat's right here in Missoula, and I'll bet there are some people that know a lot about St. Pat's here. If you look at the mission statement of St. Pat's, it emphasizes that we want to take care of the poor and the vulnerable. It's our mission. We live it. So we've been trying to expand coverage for many, many years. That's nothing new. There's just a new political football being kicked around as far as how we get there. But this is something we believe in. And it makes sense not only from a philosophical standpoint as a faith-based hospital, but also think about it for the people that we're talking about here. You're talking about quality of life. If you have health insurance, you're much more apt to go to a provider of health care in a timely manner and with the appropriate setting. In other words, you don't wait until you are at stage 7 of whatever your problem is to go to the emergency room. You go to a primary care physician early in the process. It makes your life better, and it helps the healthcare system because the emergency room is the most expensive way to access the healthcare system. And so when there was the generous offer of it, just to write a check for an uncompensated care, with all due respect, that ignores the behavior of people. That if they're just going to keep coming to the emergency room when they're at a terrible spot in their health quality, it's going to continue to cost more than it should. And when you talk about driving up healthcare costs, that drives up healthcare costs. So if you give people the coverage, a lot of good things will come from that. From an individual standpoint, from a societal standpoint, from a healthcare delivery standpoint. So that leads us to the legislative session here that we're now going through. And as it was pointed out earlier, we're at about, I think the 61st day is today out of 90. And I think Mike Dennison's still in shock from the House Bill 2 vote a couple of days ago, the 100-0 vote on the budget. We're all kind of wondering about that. But, you know, we have right now 3 Medicaid expansion bills. The first is by Representative Pat Noonan of Butte, House Bill 458. And it's pretty much straight expansion as you would expect from the Affordable Care Act. Then the governor's bill came out, and Director Opper can give you all the details about the governor's bill. It's House Bill 590, and it's sponsored by Representative Chuck Hunter, who's minority leader in the House. And that bill talks about expansion and adds in a little bit about reform regarding medical homes for the Medicaid program. The third bill is a Senate Bill 395 by the Montana Hospital Association, yay! And this bill is pretty broadly encompassing of not only expansion, but also reform. And we felt that it's important to try to cover all those bases as best as we can. And just to give you a real quick summary, some of the aspects of that are to address, we believe that the cost shift that was mentioned earlier will be contained better if we do this right. Right now, we lose money as hospitals, and the same thing's true with physicians, when you have patients that are government pay. Medicare and Medicaid typically are not something you make money on. And so in order to, get even, you have to shift those costs onto the private payers. So those people who have Blue Cross, for instance, coverage, the premiums you pay include that cost shift. And we don't like it, and you don't like it, nobody likes it, but we don't have a choice, because not-for-profit does not mean no profit. If you have no profit, doors close. Even hospitals have to make a little money to move forward into the future. So the bill will address that. Cost containment in general will be looked at. And here's an important part of it. Now, just before we start, I was asked by a young man about what you do regarding controlling costs. Well, one of the biggest drivers of costs in healthcare is chronic disease management. Diabetes, for instance. And there's a big segment of that that is a personal responsibility issue. We can't make people take their medications or quit smoking or do their exercise. But if they will, you have a lot better chance of holding down the costs because you'll be in better health. And this kind of leads into the next thing, which is, we're talking a lot now about patient-centered medical homes, which is a new buzzword in healthcare. And it's really all about collaboration, cooperation, working together so that, probably many of you have had experiences where you've had something where you've dealt with several different physicians and maybe a hospital, maybe a nursing home. And there comes a point in that continuum of care where you go, I wonder if this doc is talking to that doc, is talking to that hospital or that nursing home, or that physical therapist. And oftentimes the answer is, well, not so much. Well, one of the things we're really trying to make happen through this new delivery system approach is that there will be better communication, collaboration, cooperation. Patients will benefit from it, and really we think it'll be a much more efficient system that will hold down costs in healthcare. We've already talked about proper access, but that's one of the main parts of that bill. We want to increase mental health services. We recognize that this is an area of weakness in Montana. We want to do better at that. And then workforce. We have a lot of needs of workforce. We're very dependent on the university system. We're close partners with the university system, not only for physicians, but nurses and lab techs and rad techs, you name it. We need highly trained, educated people to help us in the healthcare system. And so what's going to happen with these bills is a great question. Those are the three that are up there for now. On Monday, 2 of the bills will be heard in front of the House Human Services Committee. That's the governor's bill and Representative Noonan's bill. Then there are some other bills that are apparently going to come forward. One by Senator Chris Kaufman of Helena, and another one that the Republicans are apparently coming forward with, and that looks like Representative Scott Richner from Big Fork will, if that bill does occur, that's apparently where that will come from. Lots of rumors going on. So anyway, we'll see how this goes. I agree with Director Opper that at the end of the session is when you're going to see the real action on these bills. And the reason is that a lot of times, in order to get something, you have to give something in a legislative session. And we'll see, it won't be a matter of who blinks first, it's who's willing to extend a hand first. And then we're optimistic that we'll see something that truly will increase coverage for low-income Montanans. Thank you.
Thanks, Mike. Well, this just in from the Missoulian, Montana legislators say Medicaid expansion bill's likely dead. Bills to expand Medicaid in Montana, one of Governor Bullock's signature proposals, are likely dead in Republican-controlled committees at the legislature. Lawmakers close to the issue say. The byline is, oh, Mike Dennison.
Good intro.
Mike Dennison is a graduate of this institution and is a reporter for the Lee newspaper's State Bureau. He's written extensively about healthcare and has nearly 30 years of reporting on Montana politics. And you get the news fresh and ready here from Mike. No one knows it better. So let's get a reality check.
Thank you, Anthony, and thanks for inviting me. It's always nice to get out of the Capitol during the legislature.
Is parking better?
No, it's worse.
That's right.
Let's talk about the story that Anthony just read from, which was in today's Missoulian, in all the other Lee papers across the state, which I wrote. What the story says is that these bills, the Medicaid expansion bills, I don't think are going to get a majority of either of those committees. The committees we're talking about are the House Human Services Committee and the Senate Public Health Committee. Let's talk about the House Committee first. It's controlled 10-6 by Republicans, so you need to get 3 Republicans to vote for that bill to get it to the floor of the House. Among those 10 Republicans, I don't see a single moderate there. They're all very conservative, and I've spoken to many of them, and they've more or less told me there's no way I'm voting for that bill. Now in the Senate, it's a little closer. It's 4-3 in the Senate, 4 Republicans, 3 Democrats. And the 4 Republicans, there's 3 of them I have talked to most of them, and they're not going to support Medicaid expansion. The 4th, Senator Terry Murphy from Caldwell, who I think is kind of a moderate, but I had one of the sponsors of the bills tell me that Murphy told him there's no way he's voting for Medicaid expansion, so I don't see any votes changing there either. I think that bill could get to the Senate floor by a blast motion, because you only need a majority in the Senate to do that. So that's possible. Get out there and have a debate. It could even pass, but it still goes to the House, still goes to the House Human Services Committee, which is a big red stop sign for these bills. Now the question is, why are Republicans so opposed to these bills in Montana? Now, I think Carl talked a lot about this, and I would agree with him just about everything he said in terms of what Republicans are thinking. But I think there's a couple other things too. Most Republicans in Montana, in the legislature, opposition to the Affordable Care Act is one of their core values. And what's happened with that in the last year? They've lost at the Supreme Court. They lost the presidential race. They lost the U.S. Senate race in Montana. So what's left? The Affordable Care Act is going to take effect next year. All the things you tried to fight and stop are taking effect, except Medicaid, which you can reject, which you can vote against, you can vote down. Why not stop the one thing you can stop if it's part of your core belief? So it shouldn't surprise anyone that they're not going to vote for this. Also, they may be afraid of getting challenged in a primary if they vote for it in the next election. And finally, alternatives are surfacing from Republicans. Mike talked about the bill from Representative Scott Richner, which I believe was introduced today. And I don't know if this is going to go anywhere, but the philosophy behind this is to find a way to get the people who are below 100% of federal poverty to be able to buy insurance. Because right now, they can't buy subsidized insurance. It's only 100% to 400%. So this is a way that the Republicans want to say, okay, instead of expanding Medicaid, we're going to somehow finance it so that poor people can buy health insurance. I don't know if that'll work, but that is the thought process. Now, of course, there are a lot of positive arguments for Medicaid expansion. You've heard them from Richard Opper You've heard them from Mike Foster, and I'm sure you've heard it from other people as well. The governor has pictures as a jobs bill, a boost for rural communities, a way to create a healthier workforce, a chance to reform the Medicaid system and the medical system. But there's one thing the governor hasn't done, which I think really would have been to his advantage politically, and that is introduce a bill a lot earlier than he did. That bill was introduced a week ago. Why didn't he introduce that bill on the first day of the session, or even pre-introduce it before the session? If he had done that, it would go to the same committee, House and Human Services. They might vote it down. They might just sit on it. But if they had done that, he could go around the state, like he's doing right now, and talking to people about this bill, and he could say, look at these guys sitting there in the House. There's a bill sitting there. They won't even send it to the House floor to have a vote on it. They won't even send it to the Senate floor to have a vote on it. Or he could say, these guys won't even vote on it at all. They're just sitting on it. I've made a proposal. Where is it? Instead, he's just talking about it in the abstract. I think it would have been a much more powerful argument for him to be able to do that. Also, if you have a bill out there in the mix, right from the beginning, you can start talking about amendments. You can start talking about alternatives. You can start talking about compromises. Think back to 2 sessions ago when medical marijuana was the biggest issue, one of the biggest issues before the session. Those bills came in right away. They went through. Some of them got killed. Some got kicked aside. Then there came new bills. They talked about those. It lasted until the last day of the session, and they were talked about almost every day of the session and worked on. Here we have this huge issue, and we have the last 30 days of the session to work on it. I think that's a huge disadvantage for the governor politically. I talked to a lot of legislators in the last month or so. A lot of them were upset about the fact that this bill was not introduced earlier. A lot of Republicans said to me, I'd like to talk to the governor about what he's going to do here, but I don't see a bill. What can we talk to him about? And also, some of the legislators who were closely involved with the issue among Republicans told me that they made some overtures to the administration, but they didn't really get much feedback. So, and they were disappointed with that. And I don't know if that was a sincere disappointment on their part or not, but that's what they said. So now we fast forward to the end game politically here. We have the last 30 days of the session. It's not over. Nothing is until the legislature adjourns. We've heard Richard say it's going to be the last day of the session. That's certainly possible. Those bills that I say are tied up in committee, deals can be cut to get them out. The governor could also take an mandatory veto and put Medicaid into another bill, and again, it goes directly to the floor. So you bypass the committees, you can get a vote up or down on it. That's kind of the nuclear option, but that could happen too. However, I think, as Mike said, in order to get something from the Republican majority, you're going to have to give something. And I was thinking about this, and there's only one thing that I could think of that Republicans want that they can't get without the governor's help, and that is a series of tax cut bills or a tax cut bill. Tax cuts are the main things Republicans in the legislature want that has to go through the governor's office that they cannot get without his help. He's got to sign those bills. So the governor could say, look, I'll sign those tax cut bills. You approve Medicaid expansion. Now, that's a political risk for both sides. You can imagine why. I mean, it's a pretty big gamble on both sides. It could be turned against either side if someone says no rather quickly, but that's just a possibility. The last thing I'd like to say is that everything I've told you could be totally wrong.
That caveat doesn't apply to anything else. It's the entire conference. Everyone else is absolutely correct, but thank you, Mike.
Well, not just to put a point on that, I'm just a reporter. I'm just looking. I'm from the outside looking in. I'm not part of anyone's inner circle. There are all sorts of things going on that I don't know about at the legislature. The legislature can do many things whenever it wants to. Motivations and circumstances can change in an instant. And who would have thought 4 days ago that the House would approve House Bill 2 100 to nothing unanimously with no debate. I don't think the people who even did it knew it 4 days ago it was going to happen. And yet it happened. So, like I said, I could be totally wrong. Anything could happen.
Thanks, Mike. Well, I'd like to open it up to the floor for questions, hear from you for the first time in the past couple of days. But before then, I'd like to give the remaining panelists follow-up. I know you were all taking notes, so what do those notes say? Richard, do you want to start a short response?
Yeah, no, I will make it quick. It is a tactic to try to kick this issue down the road for 2 years while we study it, and we blame the governor's office for coming out with a bill late. The reason why it's a tactic is 2 years from now, we will have missed out on 2 years of 100% federal funding, and it's going to be way too expensive at that point to take it on. People know this, so that's just a tactic. I hope you see through that one. So, Carl, I thought you made a lot of good points, but you did bring up bad economic policy. And with all due respect to the Hospital Association, bad economic policy has given them $11 million without adding one person to the health coverage rolls. That's bad economic policy. We get nothing for that. So I do disagree with you on that one, but that's the only thing. No, wait, there's a few other things. I think that's about it from now in the interest of saving some time.
Okay, great. Carl, just quickly follow.
I think I would, the 2 years, that's a valid point. We lose 2 years of 100% reimbursement, but I would call that more of a lure with a great big hook on it. So we're going to disagree on that, that you're not going to be able to get loose of once you swallow it. I want to reemphasize a point of the difference between health insurance and health care. Again, Medicaid patients show up in emergency rooms at nearly twice the rate of people with private insurance. Putting more people on Medicaid will cause, if the statistics stay, if the trend stays, more people to show up in emergency rooms at an even higher rate and cost even more. So I think we need to, I have a fishing license. That gives me the right to stand in a river and fish. It doesn't give me the right to catch fish. That's the difference between health insurance and health care. We should be looking for ways to expand access to quality care at a lower cost would be nice too, as opposed to just handing people a piece of paper that says they have insurance without necessarily, meanwhile we decrease the reimbursement to doctors and we decrease their actual access to care. As far as the deal, yeah, the uncompensated cost, the hospitals made a deal. And they made a deal with one side of Congress that jammed through a bill on a purely partisan vote. Now, we can argue about why it was that way, but that's the way it was. And maybe that was a bad deal. You roll the dice. They don't always come up the way you want to. I frankly don't have a lot of compassion for somebody who basically made a bet and lost. They made a bet. Now, does that mean we leave them hanging? No. Hospitals have to be compensated for the care that they provide. People that we deem needy need to get that care and have access to that care, and so we have to figure out a way to make that happen. The differences here is I don't think that this expansion is the best way to make that happen, and in the spirit of saving time, I'll stop there too.
Mike?
Thank you. Regarding the expansion, and that means that many more people will end up in the emergency room, well, they already are. The fact that they have Medicaid or don't have Medicaid, they're still coming to the emergency room. That's why reform is important as an element, a package deal when you talk about expansion, because the reform measures will try to move people toward the appropriate entryway in the healthcare system, which should be primary care, away from the emergency room. Now, the other thing I was going to mention, Anthony, is that there was a comment made by Director Opper that Medicaid patients receive lower quality care than people with private insurance, and we would. I didn't say that. I said you'll hear that argument. Oh, I thought you were making the argument. Well, for anybody that hears that argument, that's not true. When you come to a hospital or you come to a physician, it isn't a question of your ability to pay. it has everything to do with you're going to get the best quality care we can provide, regardless of who you are or what your circumstances are, every time.
Thanks, Mike. Mike, anything last?
No, since I went last, I think I kind of batted clean, so I'll just leave it to questions.
Questions? Avik.
I've heard a lot of talk here about the possibility that we've seen some other states consider, which is putting the Medicaid expansion population on the exchanges instead of on Medicaid. Maybe you have any thoughts on that possibility?
Yeah, let me just repeat the question. Talks about the possibility other states have looked into in terms of putting the additional coverage through the health insurance exchanges. Is that the Reichner bill, or?
Yes.
Yeah, I think if you were to look at the Representative Scott Richner bill, you would see some of that effort to try to move people to the exchange. And in the MHA bill, what you see is a move toward, well, can we at least talk about that? Can we consider that as a possibility? Whereas the other two bills, maybe three bills that I'm aware of, are the straight Medicaid expansion as you saw in the ACA.
Yeah, that's correct. Representative Richner's bill, which I believe was introduced today, is going to take that approach. I haven't seen the bill, but I spoke with him a couple of days ago, and what he was thinking of was coming up with some pot of money, some state money somewhere, to somehow give to those on the low end of the income scale so they could have enough money to get on the exchange and buy insurance. And of course the problem there is going to be is where do you find that money and how long will it be around, among others.
This is the first I've heard of Representative Richner's bill, but I'm familiar with the concept. And of course, one of the benefits of that from a purely, I guess, I don't want to say cynical, but from a state fiscal matter is that what you do is you take a good chunk of the folks who would be on Medicaid under expansion, and you instead move them to the exchanges where they receive, it's all federal money, there's no state match at all even down the road. Now that doesn't cover everybody who would be covered under Medicaid expansion, so that's one downfall or one shortcoming. It's also enormously expensive to do that because basically what we're talking about is a premium support system and probably not a very efficient premium support system. Now we didn't get into reforms, even though I think most of us agree reforms are needed of some kind. But some type of premium support system that gives people skin in the game, that creates responsible consumers of health care, I think is probably the way to go, a consumer-oriented, consumer-driven, reconnect the patient and the consumer, not just the customer, the third-party payer. I think that's the direction we want to go, but that's probably a discussion for a different day as far as the fixes.
Richard, we've heard everything, but not from everyone. You want to go?
Just real quickly. You can't be covered in the exchange if you're between 19 and 64 and childless. And you're under 100% of the federal poverty level. So that's the problem with the exchange. There's a big gap of the poorest of the poor. Even if they're healthy, they don't get covered.
I just clarify the point, which is that a number of states, and most notably Arkansas, is according to the governor of Arkansas, struck a deal with Washington HHS in which the 0 to 138% poverty population that was normally slated for the Medicaid expansion would instead be enrolled on the exchanges on a fully funded basis by the federal government.
They're a long way from solidifying that deal. There are all kinds of legal challenges that have come up since the governor had his conversation with Kathleen Sebelius. I wish him luck. I'm not opposed to it, but it's not as easy as they made it sound.
But if you want to introduce that idea into the debate, I think you just did. Yes, right there, sir.
When the exchanges openly or come about or the open enrollment sometime in the fourth quarter, who does the panel see as the main educational arm to help people get through the enrollment process, the Medicare or whatever expansion financially that might be available?
Good. So how do the exchanges work in terms of educating people about getting into them? Richard? I think that's your job.
Okay, and I'll talk about that briefly because apparently that's my job. See, I'm still learning it. I'm new here. Did I say that? I'm going to hide behind that as long as I can. So a couple of things about that. We have had experience vastly increasing healthcare entitlement program with our CHIP program. We added 30,000 people to it not long ago. We were very successful at it. We've invested in lots of different software that's going to make enrollment much cheaper. We know from our rolls, our TANF rolls, formerly welfare, our SNAP rolls, formerly food stamps, we know who these people are. We know how to contact them who might be eligible for the expansion, and we'll be reaching out to them. And again, we have a new IT system. We're working out the bugs that's going to really help the enrollment. The enrollment process is going to be much cheaper, much simpler now than in the future than it is now. They're going to a different enrollment system that we have like 32 categories of enrollment now. It's going to be greatly simplified. So thanks.
Yeah, Mike.
And in partnership with DPHHS, you're going to see many community organizations work together and try to get this done. I've seen this in Billings, where St. Vincent Healthcare, Billings Clinic, and Riverstone Health, which is the local community health center, work together extremely well in taking on projects like this. And the CHIP expansion that was mentioned before is a great example of a tremendous effort that was done, in that case also with the school district, in getting a whole bunch of kids signed up that were eligible for CHIP. And I think you're going to see the same amount of energy and collaboration on this one.
Other questions? Yes, right there.
A portion of the uncompensated care that you currently give to hospitals in Montana will be covered by the increase income from the Medicare program that is adopted.
So the question is, what proportion of uncompensated care currently will be covered by the increase in Medicaid expansion?
Well, it's not going to be like a light switch. It's not going to be bang and all the uncompensated care goes away. It's going to take time for people to become enrolled, and then we'll see that level decrease. But keep in mind, too, that Medicaid does not reimburse at the level of the cost of providing that service. For instance, with hospitals, and it would be, probably worse for, oh no, actually we've tried to help with physicians with a special bill to ramp up the Medicaid reimbursement for physicians to move it closer to the market, private payers. But with hospitals, just on the basic reimbursement, I think it's around 65% of cost. Now we have a special little thing, I don't want to bore you with the details, called the hospital provider fee that narrows that gap considerably. But if you, just because people become covered doesn't mean that the hospitals won't have uncompensated care. That will continue. But we're hoping at a significantly lower level.
Carl? Yeah.
So I'm not a lawyer, so I can ask a question that I don't know the answer to, and this is an honest question. I get to ask one too, I guess. If Medicaid reimburses in many cases, in a lot of cases, at rates that are lower than costs. We hear that over and over again. I think everybody understands that. Medicaid expansion is being sold as a way to compensate for reductions in federal payments for uncompensated care, DSH payments. I don't know how you make up money by losing more money with more patients. Through volume. I think of that Saturday Night Live skit where they said the old exchange currency, you got a 20, I got 2 5s, I got a 10. You want 2 5s of 10 and 10 5s or 10 1s? How do we do this? With volume. I don't know how you can do that, how you can lose more money on more people and still make up costs. And that's an honest question. That's not a setup.
No, actually, that's a good question. And the thing is, if you're a hospital that's getting zero, or a physician, you're getting zero from someone who has no insurance and no ability to pay, and now you get paid at a Medicaid rate, you've improved your financial condition because of that. You're still maybe losing a little, but you're not losing as much. Thank you. Yeah.
Other questions? We have time for 2 more. Yes, ma'am.
If the exchanges go through and the expanded Medicaid coverage goes through, for those of us who are currently being covered by the Montana Comprehensive Health Association health plan, because I have pre-existing conditions, will that program be eliminated? And if so, where do I go? I am unclear on what my options will be.
So what happens to the existing program with Medicaid expansion?
Yeah, I can make something up.
You're the expert, remember?
That's right, yeah. I don't know about your specific program. One aspect of the Affordable Care Act, probably the most important and popular aspect that is going to go through regardless of if we expand Medicaid or not, is that you can obtain coverage even if you have a pre-existing condition. So I don't know about your specific condition, but I think it's, what is it, October 2014?
That's when the exchanges will actually start on the 1st of January. But we do have somebody who can answer that here, who is Monica Lundeen, who is just chomping at the bit.
Commissioner of Insurance and Securities, Monica Lundeen. She is the real expert, and she's been doing it a little longer than you have, Richard.
Well, I just don't want you saying something that'll get you in trouble. The MCHA program will go away because really there will be no need for it any longer because you can get coverage even if you do have a pre-existing condition because you'll have guaranteed issue. So you can get coverage, most likely you'll want to get coverage through the exchange.
Right now, I'm paying $551 a month for the privilege of having a $10,000 deductible. That's a large chunk of my annual expenditures. Am I going to have even worse? Is it going to cost me more?
Honestly, I think it's going to cost you less, more than likely, because the MCHA programs are incredible. It's the insurance of last resort. It's incredibly expensive.
Let me follow up.
Thank you,
a little bit.
Commissioner.
Thanks for bailing me out.
And
Yay, Monica.
come back at 3 also for more Monica Lundeen.
And there's a bill in the legislature right now, Senate Bill 223 by Senator Mary Cafaro, that addresses this very issue. And what it does is it says that, yes, the MCHA will terminate, but in doing so, the bill allows for a kind of a phase-in process so that if you are unable to get onto the exchange smoothly, then there will be money to continue you until that smooth transition occurs. So it's like a safety net or a safe landing kind of approach with what this bill does. And I compliment Senator Cafaro for doing that bill.
So one more question. Oh, there in the back. Yes.
Are insurance companies allowed to rate you up because of a previous condition?
Monica?
No.
That was
Too fast.
okay. Okay. So a bonus question. All the way in the back. Yes.
This is directed to Richard Opper. If Medicaid expansion does occur, and more patients are going to be going to their primary care provider for treatment, how is Montana going to attract more primary care providers to fill that need?
Excellent question. Thank you.
But let me just repeat the question in terms of the shortage of primary care physicians in the event of Medicaid, or providers.
Yeah.
Thank you, Teresa.
Yeah.
Yes.
That really is an excellent question. It's something we've been thinking about. Now, the governor's bill, the best one of the bunch that are out there for consideration right now, among other things, longer term, he's got funding in it for more WWAMI students, so we can train more doctors, and he has more position funding for more residencies, because people who do residencies in Montana, of course, once they've been to Montana, they're not going to leave. That's longer term. Part of the whole medical home model is to try to not always have to go to the most expensive care you can, to have coordinated care. So if you can get by with calling in a nurse, to figure out what you need, different kinds of providers, it's a lot cheaper than going to the emergency room. And one of the things we learned on listening tours, which we were doing while we were waiting to finally craft our bill here, when we were talking to people, is what's really going to create a shortage of providers in Montana is not passing Medicaid expansion, because what's going to happen is that Washington, North Dakota, Oregon, other states that do pass expansion and have funding for this, they're going to be draining off all of our healthcare providers because people are going to be going there for healthcare. We're going to have a bigger shortage if we don't pass Medicaid expansion than we will if we do.
Well, I'd like to give my thanks to the panelists for a great discussion. I think we've got this worked out. So, all right. Well before the 90th day.